Well, good evening, everyone that's joining us this evening, and a very warm welcome to the first webinar in our brand new practitioner series. Today's topic is all about acid reflux and discussing effective strategies for managing acid reflux and supporting your patients who may be transitioning off or staying on PPIs. My name's Emma, and I'm part of the team at DR.VEGAN. We also have with us today as our host, DR.VEGAN practitioner lead Ella, and our guest hosts, prescribing pharmacist and nutritional therapist Richa. So welcome to both of you. Just quickly before I start, I wanted to mention that our practitioner webinars are intended only for professionals and not for members of the public. This includes trainee nutritionists, nutritional therapy practitioners, dietitians, naturopaths, and pharmacists. Quickly before I hand over, I wanted to give a brief introduction to both hosts. Firstly, Ella. So Ella has a passion for practitioner education and has previously worked in a lecturing and clinical supervisor role as one of their major nutritional therapy training institutes. She is also an international speaker and has travelled as far as India to speak at medicinal conferences on digestion. Ella has since put her passion for education into training practitioners at DR.VEGAN and creating materials to make clinics easier and more efficient. Ella is available by email for practitioner support, so do feel free to reach out to her if you need to. She'll be sharing her email address at the end so that you can do that. Richa, our guest host, is a prescribing pharmacist specialising in women's health, hormones and fertility. She has 17 years experience as a pharmacist and has been working as a clinical pharmacist in a general practice supporting GPs in several ways, including medication, prescribing advice to running patient-facing clinics. She's also an independent prescribing pharmacist specialising in menopause and HRT and runs a busy NHS menopause clinic, as well as having her own private integrated functional medicine clinic where she oversees all things women's health, including fertility. During her time in general practice, some of her specialist roles have included running diabetes clinics, asthma clinics, anticoagulation clinics, and a lot of complex medication reviews. Richa explained when she first started in general practice, polypharmacy and de-prescribing was quite a big thing and at the forefront of how pharmacists in practice could support patients. It was being recognised that a lot of elderly patients were taking a number of medications which had never been reviewed, and polypharmacy was becoming an issue as a lot of these patients were frail and their ability to take medications was less. PPIs, or proton pump inhibitors, which she is going to cover during this webinar, was on that list of medication. It was quite timely as she was only just starting her career as a nutritional therapist, but even then she knew and saw how many patients were actually being prescribed PPIs either unnecessarily or incorrectly, and she was on a mission to get this down. Now, just before I hand over to Ella to kick things off, I wanted to add, please feel free to ask any questions that you may have along the way throughout the course of this webinar. We're going to be doing a short Q&A session at the end where Ella and Richa will be answering your questions. We'll probably only have time to go through about 3 or 4 max, depending on time. So if your question doesn't get answered, or if there is a question that you don't feel comfortable asking on here, please reach out to Ella at the end and she will be able to help. As I mentioned, she'll be sharing her email address at the end. So without further ado, I am now going to hand over to Ella.
Fabulous. Well, thank you very much for that great introduction, Emma. And hello, everyone. So before we started, I did want to put a poll out there to see who we've got on the webinar today. But I don't know if that poll function is working at the moment. Emma, can you see a poll function on your screen?
I can't, I'm afraid.
No, okay, no worries, that's fine. We'll have to skip over that. Okay, so today we're going to be discussing acid reflux, GORD, which obviously stands for gastroesophageal reflux disease, and dyspepsia and how they're all linked, what their potential causes are and their treatments, dietary and lifestyle strategies for managing acid reflux, and also how to integrate natural treatments with conventional treatments is very important. We will discuss the new GastroAid product and the science and research that goes behind it. And at the end, you will also be emailed a handout, which you can give to your clients on acid reflux, And as Emma mentioned, if you're on this webinar live, you can try a free sample of the GastroAid supplement. Okay, so before we get started, let's have a look at a few statistics. So around 20% of the population suffer from acid reflux at least once per week. That actually equates to 13.4 million people in the UK alone. That is an outstanding number. In addition to this, proton pump inhibitors such as omeprazole, lansoprazole, and pantoprazole are widely prescribed, with up to 1/4 of people in Western countries using them regularly. That's around 6.7 million people in the UK alone. PPIs are amongst the most commonly prescribed medications globally, with annual sales exceeding £12 billion. That's essentially £12 billion being spent each year preventing nutrient absorption. PPIs are associated with potential risks when used long term, including nutrient deficiencies such as calcium, magnesium, and vitamin B12, and increased risks of stomach cancer, osteoporosis, and infections such as Clostridium difficile. PPIs also have a significant impact on gut microbiota, potentially leading to conditions like small intestinal bacterial overgrowth and disrupted gut homeostasis. And if the rate of PPI prescription carries on, we're going to be seeing a lot more people in our clinic with SIBO and other gut issues as a result. Okay, so the first image here, got a lovely picture for you to look at. The first image actually shows a normal esophageal sphincter closing, keeping the acid in the stomach where it belongs to do its job. The second image here actually shows the esophageal sphincter that's not functioning properly and that's causing gastroesophageal reflux disease or acid reflux. Now, if you look at the third image, you can quite clearly see that the acid is refluxing into the esophagus and causing that pain and inflammation. Okay, so what is acid reflux, GORD, dyspepsia, and how are they linked? Okay, so gastroesophageal reflux disease, also known as GORD, acid reflux and dyspepsia are all interrelated, yet also distinct gastrointestinal conditions frequently encountered in clinical practice. GORD is a chronic disorder characterized by the backflow of stomach acid or bile into the esophagus due to dysfunction of the lower esophageal sphincter. This leads to symptoms such as heartburn, regurgitation, and potential complications like esophagitis or Barrett's esophagus. Barrett's esophagus is a condition in which normal squamous epithelium cells in the lower esophagus are replaced with metaplastic columnar epithelium, which resembles the lining of the stomach or the intestine. And this change is thought to occur as a response to chronic exposure to gastric acid and bile. Acid reflux specifically is the specific episodic backward flow of gastric acid into the esophagus, which can occur independently or as a hallmark of GORD. So it can be because of gastroesophageal reflux disease, or it can occur independently. It is a physiological event that becomes pathological when frequent or severe. And then we have dyspepsia, which is commonly referred to as indigestion. It is a syndrome involving pain or discomfort in the upper abdomen. It can overlap with gastroesophageal reflux disorder, and when acid reflux contributes to symptoms like bloating, early satiety, and nausea. So they can be very much interlinked. Dyspepsia is also linked to things like H. pylori infection, delayed gastric emptying, and peptic ulcer disease. Acid reflux is a key feature of gastroesophageal reflux disease, and can exuberate or mimic dyspeptic symptoms. Conversely, dyspepsia may also include acid reflux as a symptom. So all three conditions are overlapping, share risk factors such as diet, obesity, and stress, and may coexist in a patient. Okay, so let's first have a look at GORD. So gastroesophageal reflux disease is basically lower esophageal sphincter dysfunction. The incompetence of the lower esophageal sphincter is caused by the transient lower esophageal sphincter relaxations or low basal tone, which allows the gastric contents to reflux into the esophagus. So factors reducing lower esophageal sphincter tone include things like high-fat meals, smoking, alcohol, and certain medications. And we'll get more into the mechanisms and the actions of how this happens later on. Delayed gastric emptying is also quite a big issue. So prolonged gastric retention increases intergastric pressure, overwhelming the lower esophageal sphincter and promoting reflux. Hiatal hernia, that's a herniation in the stomach wall. Understandably, this causes significant digestive discomfort. Esophageal hypersensitivity is a heightened sensory response to acid reflux and may amplify symptoms even when minimal exposure to gastric acid contents. So even the slightest bit of acid or reflux could cause quite a big sensation of pain. Okay, acid reflux. So contributing factors include diabetes-induced impaired function of the stomach muscles, often caused by damage to the vagus nerve, high-fat meals, and certain medications. So common triggers include dietary triggers such as acidic foods, caffeine, alcohol, and fatty foods. Lifestyle triggers such as smoking, overeating, laying down after a meal. And emotional triggers as well, such as stress and anxiety, and also some medications. So they can worsen reflux. So, for example, non-steroidal anti-inflammatory drugs and bisphosphonates. And hypochlorhydria, which is low stomach acid, so not enough stomach acid, can also lead to acid reflux, a condition known as hypochlorhydria, when stomach acid levels are insufficient. The stomach struggles to break down food, leading to improper digestion. And this can result in undigested food moving into the esophagus, causing irritation and reflux. And interestingly, many people with acid reflux are also prescribed acid-suppressing medications, but actually in this case, these might not address the underlying issue, which is low acid levels, and actually can even worsen this problem in the long term. Dyspepsia. So gastric acid dysregulation. So excessive or dysregulated gastric acid secretion can contribute to dyspepsia symptoms. Increased sensitivity of the stomach lining to normal acid levels may also exuberate discomfort. And then we have impaired gastric accommodation. So after meals, the stomach normally relaxes to accommodate food. In dyspepsia, impaired gastric accommodation can lead to a sensation of fullness, bloating, or discomfort, even when meals are small. The dysfunction may be influenced by stress, diet, or altered neurosignaling within the stomach. Delayed gastric emptying. So food can take an excessive amount of time to pass through the stomach, which is usually caused by a lack of hydrochloric acid or digestive enzymes. Visceral hypersensitivity. So that's the increased sensitivity to normal digestive processes or minor distensions in the stomach, and that can amplify pain or discomfort in individuals with dyspepsia. This may involve heightened neuroactivity in response to gastric stimuli. And again, we've got medication-induced dyspepsia. So medication-induced dyspepsia is a condition where certain drugs, such as non-steroidal anti-inflammatory drugs, antibiotics, and corticosteroids, irritate the stomach lining, leading to symptoms like bloating, nausea, and upper abdominal discomfort. This occurs due to increased gastric acid production, reduced protective mucus, or direct irritation, potentially leading to gastritis or peptic ulcers with prolonged use. And here is a nice little mind map you can refer back to that has everything on there that we just discussed, a nice little image for you. Okay, so there are actually a few conditions that you do need to be aware of when you're working with clients with acid reflux, and I think it's always a good idea to send your clients to the GP for further investigating if they haven't had that done so already. So I'm going to work on the right hand side and I'm going to work clockwise. Okay, so the first one is diabetes-related gastroparesis. So diabetes-related damage to the vagus nerve that impairs the stomach muscle function. We've also got Helicobacter pylori infection. So H. pylori is a common cause of chronic gastritis and peptic ulcers, both of which can present as dyspepsia symptoms. The bacteria can disrupt the stomach's protective mucosal lining, allowing acid to irritate the underlying tissues. H. pylori also increases ammonium, which reduces gastric acidity. We've got Gilbert syndrome, and this is a benign liver condition affecting the bilirubin metabolism. And this can lead to impaired digestion and delayed gastric emptying, increasing the risk of acid reflux. We've got achalasia. Achalasia is a disorder where the esophageal muscles fail to relax properly, causing food to remain in the esophagus longer and increasing pressure on the stomach, the esophageal sphincter, and leading to acid reflux. A hiatus hernia. So a hiatus hernia occurs when part of the stomach protrudes through the diaphragm into the chest, weakening the lower esophageal sphincter and allowing acid to reflux into the esophagus. We've also got SIBO, small intestinal bacterial overgrowth, and that is an overgrowth of bacteria in the small intestine that can cause bloating and increase intra-abdominal pressure, which is when we which can then push pressure onto the stomach and push the acid up into the esophagus. We've also got food intolerances. This is quite a big one for acid reflux. So food intolerances such as lactose or gluten intolerance can cause digestive disturbances like bloating, inflammation, increasing intra-abdominal pressure and contributing to acid reflux. So with quite a lot of my clients, I do recommend that they have an IgG food intolerance test because it really helps me to identify the root cause of what's going on. Now, herpes, particularly when it affects the esophagus, is called hepatic esophagitis, can cause inflammation and irritation, weakening the esophageal lining, making it more susceptible to acid reflux. And then we've got Zollinger-Ellison syndrome. So this is a rare condition where tumours in the pancreas or duodenum cause excessive stomach acid production, leading to severe acid reflux and peptic ulcers. So now you can look at this, this image, this chart, and you can see, there are so many other things that can be causing a problem with acid reflux. So it is really important that your client does get checked out to make sure it's none of these conditions. Okay, so now we have a wonderful picture here of the vagus nerve. So the vagus nerve is a mixed nerve containing both sensory and motor fibers. So it extends from the brainstem and goes right the way down and goes to various organs, including the esophagus, the stomach, and the intestines. So in the stomach, it controls gastric motility, gastric secretions, including hydrochloric acid secretions, and coordination of the lower esophageal sphincter as well. So it's very, very important that we look at the vagus nerve when we're looking at clients and helping our clients. The vagus nerve stimulates stomach acid production via several mechanisms. So we've got the parasympathetic activation. So then, because the nerve is part of the parasympathetic nervous system, that's also known as the rest and digest system, when activated, the nerve releases acetylcholine at its nerve endings in the stomach. Acetylcholine binds to receptors in the stomach lining, which triggers the release of hydrochloric acid, which then is essential for digestion. The vagus nerve stimulates G cells in the stomach to release gastrin, a hormone that enhances parietal cell activity, increasing gastric acid, stimulates enterotrophin-like cells to secrete histamine, and further stimulates hydrochloric acid release. The vagus nerve stimulates Chief cells in the stomach to release pepsinogen, which is activated by stomach acid to form pepsin, which is a protein digesting enzyme. The vagus nerve is involved in acid reflux through its control of the lower esophageal sphincter and through gastric emptying. So the vagus nerve coordinates the opening and the closing of the lower esophageal sphincter to prevent stomach acid from refluxing into the esophagus. If the vagal nerve control is disrupted, which could be due to nerve damage or excessive vagal nerve stimulation, which can be caused by stress or emotional shock, some medications, pain, or even standing for long periods of time, this can trigger the inappropriate relaxation of the lower esophageal sphincter, allowing acid to flow backwards into the esophagus, causing acid reflux or gastroesophageal reflux disease. So actually, part of our questionnaire that we give to our clients is, are you sitting down, when you're eating, or how do you eat? What are your meal times like? Are you stressed? Are you taking time to relax before your meals? These are all very important questions to help us get to the bottom of why your client has acid reflux. Okay, so some chemicals in food also influence neurotransmitters that inhibit the lower esophageal contraction, leading to relaxation and reflux. So these might include nitric oxide. So that acts as a smooth muscle relaxant in the lower esophageal sphincter. So foods like chocolate, peppermint, or alcohol can stimulate nitric oxide production, which reduces the lower esophageal tone. Serotonin and dopamine. So these influence gastrointestinal motility, and caffeine and alcohol can actually increase serotonin and dopamine release, which reduces the lower esophageal sphincter contraction. And then we've got GABA. So GABA inhibits excitatory signals in the lower esophageal sphincter, leading to the relaxation of the esophageal sphincter. And chocolate and alcohol stimulate GABA receptors, which weaken the lower esophageal sphincter. So it's bad news for chocolate lovers, I'm afraid. And the vagus nerve also ensures proper gastric motility by coordinating stomach muscle contractions. So impaired vagus nerve function can actually slow down gastric emptying, leading to a buildup of gastric contents, which increases the risk of reflux. Now, dysfunction of the vagus nerve can contribute to excessive or insufficient stomach acid production or worsen acid reflux. So conditions like stress or hypervagal tone may lead to overproduction of stomach acid and excessive relaxation of the lower esophageal sphincter, worsening reflux. And conditions such as diabetes, neuropathy, surgical damage can also impair vagal nerve function. So the vagus nerve is something you do need to take a big look at when you're dealing with people with gut issues in general, but also acid reflux. Okay, so we were going to have another poll here, but unfortunately the poll function isn't working. So we are, okay, in a minute we're going to go over to Richa. And just to remind you, Richa is a fantastic clinical pharmacist and nutritional therapist, and a functional medicine practitioner specialising in women's health and hormones. So she has actually been working on the NHS as pharmacist for nearly 20 years. And she's got her own integrative health practice as well. So she's more than qualified to talk to us about everything PPIs and acid reflux. So Richa, over to you.
Oh, thank you, Ella. That was brilliant so far. And thank you, Emma, as well for your intro. So I'm going to be speaking about proton pump inhibitors, or PPIs, their shortened name. I'll be discussing the commonly prescribed PPIs, risks of long-term use of PPIs, and when PPIs are appropriate and how to use them judiciously as well. So we start with an overview of PPIs. So it's going to be more focused on how they actually work. So Ella's explained about the lovely vagus nerve and how we need that to actually start off the process of producing acid from the parietal cells in the stomach epithelial lining. So then when PPIs come into the equations, PPIs are actually a prodrug. So that means they are inactive until they reach an acidic environment. So when we take their typically capsules, and then once they reach the stomach, they'll then be activated. So after being absorbed in the intestines and traveling through the bloodstream, PPIs accumulate then in the parietal cells of the stomach. So they target those actual parietal cells. And then when they come to the acidic environment, they are converted into their active form, which binds irreversibly to that hydrogen potassium ATPase, or what's otherwise known as the proton pump in the parietal cell membrane. This then blocks the pump from secreting hydrogen ions. So we know hydrochloric acid is stomach acid. And then this significantly reduces acid production. So there are other types of medications which can also block the stomach acid production. So they are antacids or H2 blockers. So they actually work temporarily, whereas PPIs suppress acid production for more than 24 hours. Because we need actually new proton pumps to actually be synthesized before the acid secretion can then actually resume. So that I thought that was quite interesting. So they actually completely halt the proton pump from producing its acid. So a single dose can actually inhibit the acid production by 90% within a few days. So that's quite significant. So very quickly that acid production reduces very significantly. And then the full secretion will return only after, like I was saying, the new proton pumps are actually synthesized. And that can take up to 5 days, so between 3 and 5 days. So how do we recognize on our patient intake forms or our nutritional therapy questionnaires if a patient, or sorry, I'm used to saying patient because of obviously NHS, but it's patient client, is taking a PPI? So a big clue is in the name. So the drug will always end with prazole. So as Ella's already mentioned, we've got omeprazole or omeprazole, as my patients, elderly patients used to say. There's pantoprazole, esomeprazole, lansoprazole, and rabiprazole. So these are all the ones that are commonly prescribed within the UK, but there might be others if your patients are abroad. And then I thought it was also worth noting that some of these are actually also available over the counter. So you can get them in chemists, pharmacies, and even supermarkets. So in lower doses, so not in prescribed doses, but it's also worth asking patients, clients, whether they are actually taking anything non-prescribed. And the GP may only give one dose for a certain period of time, but obviously, patients, clients, they can have quite severe symptoms, and then they might feel they need an extra top up and then be buying an extra amount from elsewhere. So I'm going to just skip to the bottom part for the moment. So when our PPIs, when are they used appropriately and judiciously? So typically PPIs should actually only be prescribed for about 6 to 8 weeks. So that's what the product literature says. That's what our British National Formulary says. So that's our guide of how to use all the medications. But we often see patients, and this is what Emma was talking about in my intro, we used to see patients prescribe these for years, let alone weeks. But there are a few instances where we can use them and we should use them longer term. So if a patient's taking a medication such as clopidogrel or aspirin, these are both medications that can actually irritate the lining of the stomach, and they can cause what we call micro tears, and that can obviously cause bleeding, micro bleeding, which over time can then cause more severe issues such as loss of iron or bleeding risk. So if a patient is on either clopidogrel or aspirin, they're used for things like after a mini stroke or after a heart attack. And especially if the patients are older, so if they're over the age of 65, their bleed risk then increases. So we need to keep them on the PPIs. Ella did mention Barrett's esophagus. So that is an indication for long-term PPIs. It is when the lining of the esophagus can actually become irritated, and then due to the acid, and that can then actually change the cells, and they can actually become precancerous as well. So that's really important, and they don't have that sort of exposure to that stomach acid. So similarly to aspirin and clopidogrel, long-term non-steroidals, so NSAIDs such as ibuprofen, naproxen. So again, you want to use PPIs alongside to protect the stomach lining. So long-term NSAID use is typically for people who have conditions such as rheumatoid arthritis. So, inflammatory conditions where they're obviously in a lot of pain. And then another instance may be peptic ulcers due to, say, H. pylori or NSAID use as well. So then, obviously, if patients are needing to use their medications for a longer term, there can then be risks associated with that. So typically, we know that the stomach acid is super important. So I always explain that if we take the acid out of our stomachs and put it on our skin, it would actually burn through our skin. It's that potent and that powerful. So if we think about that, then we then think about well, how does that benefit us? So it's stomach acid is needed for protein digestion. So we need it for breakdown and absorption of food and of micronutrients. So protein digestion obviously then breaks down into amino acids. So then we're looking at things like muscle mass going over a longer period of time. Nutrient absorption, so macronutrients, micronutrients are B12, iron, magnesium, calcium, sodium, so quite a few. And then there can be longer term risks associated with those particular nutrients, which we're going to go on to as well. And then, like I was saying, the stomach acid is so powerful. So it's actually our first line of defense against any pathogens that enter our bodies. So that hydrochloric acid kills harmful bacteria, fungi, parasites before they get a chance to actually do damage or reach the intestines. So that those infections can include things like small intestinal bacterial overgrowth, SIBO, H. pylori overgrowth, which can then cause bloating, reflux, ulcers, as Ella's mentioned. Also Clostridium difficile as well, which is just not nice for our patients and clients. And then even pneumonia. So it could be any type of bacteria or fungi that stomach acid is actually protecting us against. Long term as well, we've mentioned already hypochlorhydria, so that's the low stomach acid, and also it's very hard to sort of distinguish between the two. So at some point it can actually tip from that high stomach acid to that low stomach acid. And then longer term as well, just even more digestive issues. So stomach acid stimulates the release of enzymes and bile. So over time, it affects then fat digestion, and then even carbohydrate digestion that causes, again, bloating, gas, constipation. And actually, one thing also is to note that in elderly, due to sort of these lack of nutrients and things, it can actually add to their frailty. So we look at something called a frailty score, and even increase their risk of falling. So I'll discuss that as well. So I think next slide. Okay, brilliant. So I'm just going to talk a bit more about these nutritional deficiencies. So magnesium, B12, you can see how high calcium deficiency is there, iron, zinc, and also sodium as well. So it's one thing, obviously, having the deficiencies, but then if they do become chronic and long term, they can lead to other things. So B12 deficiency, so we can get B12 related anemia. We can also get neuropathy, so tingling in the hands and feet. Anemia will lead to things like weakness and brain fog. Magnesium deficiency, so magnesium, obviously we know it's used in over 300 enzymatic processes in the body. So lack of magnesium is related to muscle spasms, weakness, even heart palpitations, arrhythmias. My favorite topic, hormones. We need magnesium for our hormones. It can also be related to chronic, again, long-term magnesium deficiency, anxiety, irritability, can contribute to insomnia as well. Calcium and magnesium together, there's a huge risk of then osteoporosis from, again, a long-term perspective, and osteopenia, which just sort of precedes full-blown osteoporosis. And then that also then leads to high risk of fractures. Again, for older patients, they are at higher risk of falls as well. So it's really, really important that we discuss all of these. Iron deficiency, similar to B12, we can get iron deficiency anemia, and then symptoms associated with that can be fatigue, dizziness, shortness of breath as well, because we need that iron to be delivered all around the body, and it's, you know, part of that red blood cell as well. And zinc deficiency. So again, zinc is linked to hormonal balance. It's really important for our immune function. And there's obviously that bidirectional relationship as well with digestive health. So we need the zinc to produce the hydrochloric acid, but then obviously lack of zinc can be caused by hydrochloric acid. And then hormones as well with zinc. And sodium deficiency. So sodium not as well known, and it's on this chart, but so PPIs can actually be related to, can actually cause sodium deficiency. And actually one of the big things is drug-related hospital admissions. So a lot of hospital admissions are actually due to drugs. So if a patient presents with a fall, confusion, dizziness, they will actually review their medication. And one of the actually underlying causes of that can actually be low sodium levels. And actually at that point, PPIs are actually stopped, and patients will then be changed onto other medications as well. Okay, that was it in terms of nutrient deficiencies. So now we're going to speak about sort of collaborative management strategies. So that's combining how we work as nutritional therapists to support our patients, and also then working alongside their prescribers or healthcare practitioners. So I'll talk a bit about how to wean off PPIs safely and how we can manage that, and then also recognizing when to refer patients for specialist intervention. So as nutritional therapists, we've obviously got to be very, very careful about how we manage the drug side of things. We are not in a position to be able to sort of recommend stopping any medications, but we can work alongside their healthcare practitioners, writing letters, etc., or giving our patients leaflets, you know, which they can then take to their GPs. But it's really important to stress that they shouldn't just be coming off medications without speaking to someone first. So one of the things I used to come across a lot in practice was patients would come across this information, nutritional deficiencies, etc., or they'd just sort of think, I've been taking this for a really long time, I want to stop this medication, and they would just stop it abruptly. And then they would get something called rebound reflux, or rebound acid hypersecretion is another terminology for it. They'd feel dreadful. So if you just remember, I spoke about PPIs and how they act so quickly, and they can really reduce that acid production. And so if they came off them, they'd get a rebound reflux, and it would literally within 2 or 3 days, they'd be back onto their medications. So it is difficult to stop PPIs when they've been taking them for a long period of time. So how I used to advise or manage it was first, obviously, looking at how we can support that acid production. So we want to advise them about their trigger foods, caffeine, alcohol, fatty foods, spicy foods, heavy meals, not eating too late at night. We want to talk about lifestyle, which Ella spoke about as well, so eating slowly, chewing thoroughly, avoiding too much fluid just before, during and after meals, deep breathing to activate your vagus nerve, not eating in front of screens. They can use antacids or even something like Gaviscon just for a short period of time, just whilst they're weaning off. So all of this should be put into place before they start to wean. So rather than stopping abruptly, just taper it down and wean it off. So what that would look like, if someone, for example, was taking 20 milligrams of omeprazole, then I would advise them to take 20 milligrams and 10 milligrams on alternating days. So this is when we need to speak to their healthcare providers just to get a smaller dose prescribed for them as well. So that would be for 2 weeks, the alternating dose. Then they'd go down to 10 milligrams for 2 weeks. And then they'd do sort of 10 milligrams every other day. So that would be a good way to wean them off slowly so they didn't get that rebound and reflux. And also just saying to them, if you do get it, then it should subside itself off. You'll get this initial rebound, but then it will just kind of calm itself down. So just persevere with it. So that would be how to wean off, but also we could also look at treatment doses versus maintenance doses. So if someone comes with an ulcer, for example, or they come with a gastritis or reflux or GERD, then they might need a higher dose for a period of time. And then that's when we'd want to review it, and then we would then move them onto a lower dose if they needed it for a longer period of time. So again, with all of the kind of side effects related, it's when they're taking medications for high doses for longer periods of time, they're going to be more susceptible to all of those that we've discussed earlier. Okay, so when to refer for specialist intervention. So it's just about our red flags, really. So we know these from our intake forms again. Any unexplained weight loss, any difficulty swallowing, any change in bowels. So the difficulty swallowing can be related to that Barrett's esophagus that I was speaking about before. If they do notice any bleeding, so that can be in their stools, it can be when coughing as well. All of these, or persistent anemia is another one related to bleeding. So all of these would be definitely, we should be then referring back. And also other things just to know are if nutritional deficiencies are not correcting themselves, that would be another time to refer back. So I hope that was helpful.
Thank you, Richa. That was very, very informative. Wonderful. Okay, so let's have a look at the next slide here. Okay, so now I'm going to talk about some dietary strategies that you can integrate with your clients to help with their reflux journey. So the first thing we're going to look at is anti-inflammatory foods. So a diet rich in plenty of fresh fruit and vegetables, whole grains, omega-3 fatty acids. Try to get organic foods if possible. And all of these foods reduce esophageal inflammation caused by the chronic acid exposure. And also avoiding pro-inflammatory foods, so things like processed meats, refined sugars, trans fats. These all may irritate the mucosa. So decreasing these foods can decrease that irritation and improve symptoms. Another thing you're going to look at is the size of their meals and the timing of their meals as well. So they want to be having small, frequent meals. So this reduces gastric distension, lowers intra-abdominal pressure that can weaken the lower esophageal sphincter and trigger reflux episodes. And also they want to be avoiding trigger foods. So foods such as caffeine, chocolate, alcohol, spicy foods, and acidic foods can actually weaken the lower esophageal sphincter or directly irritate the esophagus. So personalized elimination diets can help identify and avoid specific triggers for each patient. And honestly, this is one of the first things I would do with my clients, along with their food intolerance test, is get them to keep a food diary and try them on an elimination diet and see what triggers their reflux for them. Okay, so now we have some really interesting research here. So this research was published in the Digestive Diseases and Sciences journal and was conducted on 100 people with gastroesophageal reflux disease, and found that most people with gastroesophageal reflux disease could identify at least one food trigger. So the point is here that there most likely will be a food trigger, and there might be more than one as well. And the most common food trigger for their reflux symptoms was actually spicy food. So 62% actually had a sensitivity to spicy foods. And in joint second place is chocolate and pizza. So I'm sorry, all you chocolate lovers out there and pizza lovers, Tomato was at 52%, along with fried foods as well. So these had significant impacts on those people's reflux symptoms. And just over half still had gastroesophageal reflux disease at the time of the follow-up. So that's amazing. You know, just by eliminating their trigger foods, you could potentially eliminate or significantly decrease acid reflux in 50% or 45% of clients that come through your door just by doing this one simple trick. And heartburn reporting also decreased from 93% to 44%, again a significant reduction there. And regurgitation decreased from 72 to 28%. So really significant and profound changes just by doing something as simple as watching for trigger foods and seeing what affects your client. Okay, so lifestyle modifications. So the first one we want to look at is weight management. So excess abdominal fat actually increases intra-abdominal pressure, weakening the lower esophageal sphincter and allowing the acid to reflux. So weight loss can reduce this pressure and improve the lower esophageal function. So even a small amount of weight loss can have a big impact on acid reflux symptoms. So raising the head at bed before nighttime, so you can put a couple of pillows under you to make sure you're a little bit more elevated, and that utilizes gravity to prevent the gastric contents from moving into the esophagus. And it's really important to get the timing of meals right. So eating no less than 2 to 3 hours before laying down. So avoiding those meals right before bed, and that helps to ensure that the gastric emptying is complete before bed and then reduces the risk of nighttime reflux. And stress management techniques are also very important. We discussed extensively the vagus nerve earlier, and that is affected quite strongly by stress. So encourage your clients to do daily practices such as deep breathing, meditation or yoga, and this helps to calm down the vagus nerve and helps to regulate that reflux and the vagus nerve's impact on digestion. So practices like yoga are really good for weight loss, as well as helping to calm down that vagus nerve as well and reduce stress. Okay, so now I'm actually very excited to introduce you to our new product, called GastroAid. So this is our first product for acid reflux and all these things like dyspepsia that can contribute towards acid reflux. So I'm really, really excited to introduce you to this today. And this product has actually been expertly formulated to target both the cause and the symptoms of acid reflux. So inside we have betaine hydrochloride, and I'm going to go into these ingredients in a lot more depth in a couple of slides. But just as an overview, we've got the betaine hydrochloride, we've got amylase, peptase, protease, we've got chamomile flower, as well as artichoke leaf, amla berry, fennel, caraway, and bamboo silica. So really, really good blend. Okay. So we can also use GastroAid in combination with a few of our other supplements that work really well together. So the number one is GutWorks. So that contains 50 billion colony-forming units with 8 different strains in delayed release capsules. So that helps to regulate the intestinal microflora, and of course dysbiosis can contribute towards acid reflux. We've also got Debloat Detox. So if anybody is really struggling with bloating or kind of liver function, this can help to reduce that bloating, help the liver to work properly, and that reduces the intra-abdominal pressure on the stomach as well. So that's a really nice one to use in conjunction with the GastroAid. And we've got the fiber complex as well. So fiber is amazing, not only for weight loss, because it helps you feel full, but also it acts as a prebiotic. So feeds those beneficial bacteria colonies in the gut and helps food move along the digestive system in an efficient manner. Again, helping to reduce the delayed gastric emptying and that intra-abdominal pressure that we often see in clients with acid reflux. Okay, so now we're going to have a look at the individual ingredients in a little bit more depth. So the first one, we've got amla berry extract. So that's also known as Indian gooseberry. And it's a very potent natural remedy and research-based for managing acid reflux and promoting digestive health. So it's very rich in vitamin C, tannins, flavonoids, and amla exhibits strong antioxidant and anti-inflammatory properties, which can help protect and soothe the esophageal lining that is irritated by gastric acid. So its bioactive compounds include gallic acid, egalic acid, and emblicanin. And these support the mucosal defense by enhancing the production of protective gastric mucus, thereby reducing the acid damage caused to the stomach and the esophagus. And additionally, amla is known to improve gastric motility and regulate stomach acid production, which can help prevent acid reflux episodes. A study published in the Journal of Integrative Medicine aimed to evaluate the efficacy and the safety of amla, concluded that amla was safe and effective for managing symptoms of NERD. So NERD is non-erosive reflux disorder. And its gastroprotective and mucosal properties make it a promising option for anybody in your clinic that's got acid reflux or gastroesophageal reflux disease. Okay, so let's move on to caraway powder. So this can also be used to manage acid reflux and GORD due to its ability to enhance health through multiple mechanisms. So the seeds contain compounds such as carvone, limonene, and these exhibit strong anti-spasmodic and antimicrobial properties, and they help to relax the smooth muscle of the gastrointestinal tract and reduce stomach spasms and alleviate symptoms of dyspepsia, often associated with GORD. Caraway also supports gut health by modulating the balance of gut microbiotica, reducing the harmful bacterial overgrowth and promoting the growth of beneficial bacteria. So individuals with small intestinal bacterial overgrowth, also known as SIBO, SIBO is actually linked to GORD. Okay, so people that with SIBO and acid reflux may especially benefit from caraway due to these properties. And additionally, the antioxidant properties of caraway derived from chemicals like their flavonoids reduce the oxidative stress and inflammation and help to protect the gastric lining from irritation. Okay, so fennel seed. So again, fennel seed has diverse applications for gut health, and that's due to its contents of anethol, estragol, fenchone, collagenic acid, quercetin, rutin, camphorol, and anophyrin. And as well in there, you've also got some scopolamine and some biliferine. And these bioactives relax the smooth muscle of the gastrointestinal tract and actually reduce esophageal spasms and help to alleviate the symptoms associated with acid reflux. And additionally, fennel's anti-inflammatory properties are driven by its phenolonic compounds, such as collagenic acid and flavonoids like quercetin. They help to soothe the irritation of the gastrointestinal lining and the lining of the esophagus as well. So fennel also promotes digestion by stimulating gastric motility, reducing the bloating and minimizing the buildup of gas, which can worsen acid reflux symptoms. Okay, so German chamomile flower extract. So that contains a whole host of beneficial compounds such as chemozulin, alpha-bisabodyl, apinogen, luteolin, quercetin, caffeic acid, ferulic acid, matricin, bellerophone, herein, and polysaccharides and tannins. So that's actually quite a long list for one herb. So it's very, very potent. And these are anti-inflammatory and they help to protect the tissues from oxidative damage. So German chamomile improves digestion and it also improves indigestion because it helps to control that gastric emptying and reduce that inflammation that's in the esophagus and the esophageal sphincter. Okay, so artichoke. Now, artichoke is being used quite a lot with individuals with gastroesophageal reflux disorder, and that is because it contains constituents like collagenic acid, luteolin, apigenin, cyrenin, silymarin, sesquiterpene, lactones, and tannins. And artichoke actually promotes bile secretions and accelerates the gastrointestinal transit. So that reduces the risk of food lingering in the stomach, which can contribute towards acid reflux. And artichoke also possesses anti-inflammatory properties. And again, these can help to soothe irritation of the esophagus. And there's some research that concludes that artichoke actually improves the upper gastrointestinal symptoms of dyspepsia. And a clinical trial found that artichoke leaf extract can improve the quality of life and provide relief of upper gastrointestinal symptoms of individuals with dyspepsia. Okay, so bamboo, so silica from bamboo extract. So we've got the bamboo extracts in here, which are rich in phenolic and phenolic compounds and flavonoids, which can also neutralize reactive oxygen species and help to decrease that damage that's caused by the mucosa. Sorry, that's caused to the mucosa by the acid. And the studies show that the bamboo extracts actually suppress pro-inflammatory cytokines, including interleukin-6, in the inflamed tissues. So again, it's really, really good at helping to soothe those damaged tissues. We've also got some digestive enzymes in here, so they include lipase, amylase, and protease, and they all help with the breakdown of the 3 major macronutrients. And the research actually concludes that digestive enzymes and in combination have been used for a long time and that do actually have a good response in improving various symptoms of dyspepsia due to functional and organic causes. And the studies show the favourable role of oral digestive enzyme supplementation in patients with functional dyspepsia due to inadequate digestive enzymes can reduce symptoms of functional dyspepsia. And enzymes may reduce the amount of time that food stays in the stomach, reducing pressure on the lower esophageal sphincter and reducing digestive symptoms. And finally in here we've got betaine hydrochloride. So this is used to aid the digestion, and structurally betaine consists of, well, it's also known as triamethylglycine. It's naturally occurring compound derived from choline and combined with hydrochloric acid. And in clinical practice, betaine hydrochloride is used to address hypochlorhydria, which is low stomach acid, and may contribute towards symptoms that are often associated with acid reflux. So we want to make sure they've got that correct level of stomach acid to help with their reflux symptoms if they've got hypochlorhydria. When gastric acid levels are insufficient, the digestive process is compromised and can lead to symptoms that mimic esophageal reflux, including bloating, indigestion, and regurgitation. When ingested, betaine hydrochloride dissociates in the stomach into betaine, which is then metabolized as a methyl donor and contributes towards homocysteine metabolism. Hydrogen ions, such as chloride ions, they also combine to restore gastric acidity, and the acidification mimics the natural gastric acid and improves digestion efficacy without requiring the stimulation of the parietal cells. So even if your client has got issues with damage to the parietal cells, you can use betaine hydrochloride and it will help to digest their food effectively. Okay, so betaine hydrochloride benefits patients who experience symptoms due to poor lower esophageal tone, delayed gastric emptying secondary to low acid production, and due to inefficient protein digestion, leading to increased intra-abdominal pressure. Okay, so over to you, Emma.
Amazing. Thank you both so much for that. That was really insightful. I'm sure everyone felt the same. So we do have time for some questions. We've had some really good questions come in. Just quickly before I go into those, just a quick reminder to everyone that you will be sent these slides after the webinar is over, just in case anyone is frantically writing anything down or making notes, you will be getting these slides to use afterwards. And also there was just a slight typo on one of the slides. So GastroAid is available on our website for $26.99, not $27.99. And if you subscribe, you get 15% off that price. So let's go into some questions. So the first question is, can GastroAid be taken alongside PPIs? I don't know who wants to take that out of either of you.
Shall I go for it?
Yeah.
Yeah, I wouldn't have thought why. I wouldn't have said no. So I would just suggest that they're taken at separate times. So PPIs are acting to reduce stomach acid, But obviously then if we're going in with things like betaine, just check very carefully with kind of history with the patient or client. But otherwise I would trial it and see how they get on. Yeah, but just not at exactly the same time of day.
Great. Thanks for that, Richa. Next question we've got here is there a risk of using betaine if there is stomach inflammation?
Okay, I can answer this one. So it really depends what's causing the stomach inflammation. So for example, if you've got inflammation caused by Helicobacter pylori, then basically what the Helicobacter pylori do is they bury into the stomach wall to hide from the acid. They produce ammonium, which lowers the acidity to help them survive. So I would say you've got to figure out why your client's got irritation of the stomach. If it is due to H. pylori, you putting in some extra acid can actually be helpful because it does help to kill them. But you also need to be very careful. Like if they've got a gastric ulcer because of H. pylori, you wouldn't want to put stomach acid in then because it would be very, very painful. It might be that they have another infection which would need addressing first. So again, it's really a case of working with their GP or their hospital consultant to try and work out why they've got that inflammation. If they've got inflammation because the acid is refluxing and it's causing inflammation in the esophagus, then obviously you need to get to the bottom of why they've got their acid reflux. And actually this product might help them. But it's going to be a case of trial and error, and also make sure you are working with their practitioner to figure out exactly first why they have the inflammation before you put in the stomach acid, the betaine hydrochloride.
Wonderful. Thanks, Ella. Next question we have is, can the digestive enzymes be helpful in patients with pancreatic insufficiency too? And are there any studies looking at the effectiveness of the different herbs?
Do you want me to go for that one, Richa?
Yeah.
Okay, fine. So I would say if someone has a specific pancrease deficiency, then I would be putting in maybe pancreatic enzymes. But there's no reason why you couldn't add in both. So you could add in these digestive enzymes and as well as something like pancreatin and purified pancreatic extract. There's no problem using them together. But again, you've got to work out why they've got that pancreatin deficiency. And that comes down to, investigating, are they nutrient deficient? Have they got other issues going on? So yeah, you can use them together, but if they have a specific deficiency of the pancreas, I would also use it in conjunction with pancreatin. I hope that answers the question.
Fab, thanks, Ella. Next question is about GastroAid. How long does someone need to take GastroAid before they start feeling a difference and seeing a difference? Is it something that can be taken long term?
Yeah, so it should be helpful from your first meal. If you have acid reflux due to low stomach acid or inefficient digestion, then you should see it from your first meal, absolutely. I mean, there's no harm in taking it long term, but what I would say is you actually do need to work out why your client isn't digesting their food effectively on their own. So this product is really, really good at giving to your client while you're working on other issues. And those issues might take 6 months to a year to address, but you do need to address them in the long run. But this is a really good product to take to help them digest in the intermediate term while you are addressing those other issues.
Amazing. This is great, by the way. We've had lots of great questions in. So the next question we have is this supplement suitable for someone with hiatal hernia? Apologies if I pronounced that wrong. Hopefully it's correct.
I would say with hiatal hernia, be very, very careful because there's a structural problem that's causing the acid to reflux rather than it being a lack of stomach acid or a lack of digestion enzymes. So if you're going to then put in the betaine hydrochloride with someone that's got hiatal hernia, I probably wouldn't recommend that, to be honest, because it might make them worse. So I would say in that case, no.
Perfect. The final question we have here is, what is the age group? I would assume that means who can take GastroAid.
Yeah, so to be honest, when you're taking things like betaine hydrochloride, it is best to just keep it for adults. If you've got a specific problem in children, obviously you need to work out why they've got that issue in the first place. But yeah, I wouldn't give it to children. I would just keep it for adults only. And also, sorry, just another note as well. So like, you need to swallow the capsule. So a lot of children can't swallow. So I wouldn't recommend opening it up or like putting it onto food, because it has got the betaine hydrochloride in there. So you do actually have to swallow the capsule. So, I would say no to children.
Great, thanks, Ella. And Richa, just a question for you. Would you recommend probiotics alongside PPIs to help decrease digestive side effects?
So yeah, I think once we lose our acid production, that can then lead to things like dysbiosis. That can then cause things like bloating and discomfort. So we want to be doing as much as we can really to support the digestive system. So you can use probiotics alongside, definitely. But again, I'd just take them at a different time of day, just because they're going to counter each other. But also, as well as probiotics, and also looking at things like enzymes, which Ella's mentioned. You can also look at bitters as well. So bitters are really good to sort of stimulate the digestion. But I think, like with everything we've mentioned, it's really important to know the reason why people are taking PPIs. So, again, if there's ulcers, etc., probiotics are not going to do anything. But other things that we're putting in might then like irritate or aggravate, which is the last thing we want to do, making things worse. But yeah, probiotics are absolutely fine.
Great, thank you. Just one final question for you then, Richa, which is, are there any lab tests that you would recommend for monitoring nutritional deficiencies in long-term PPI users?
Yeah, so if they are on them long term, we've mentioned all those deficiencies that can start to crop up. So the B12, the iron, the sodium, what else was it? Zinc, calcium obviously is really important, magnesium. So all of those can be covered on a standard blood test. So you can look at the individual nutrients themselves, but you also want to be looking at things like a full blood count. So you want to be looking at red blood cell levels, size, volume, etc. So that will give us a good idea. Also, if there is a history or any indication of any osteoporosis, then you might want to consider bone scan at some point if it's long term. If they've got a family history of osteoporosis, that's something else that could be looked at as part of just monitoring.
Great, thank you so much. Okay, well, perfect. That brings us to the end of our questions. Thanks so much, everyone, for all of those great questions. And that also brings us to the end of our webinar this evening. So a huge thank you to everyone who has tuned in this evening for joining, and to all of those who will be probably watching this on demand, who signed up. We hope you all found it really, really useful. A final reminder that we will be sending out the recording of this webinar tomorrow, along with the slides and some other bits and pieces, including a free handout, which breaks down PDF document which you can download, which breaks down how best to support your clients with acid reflux. And to those of you who have joined live this evening, as a thank you, we are giving you the exclusive opportunity to try our new GastroAid formula free of charge. So details of how to claim this will be included in the email tomorrow. And yeah, just a note to say that we are only giving this opportunity to those of you who have tuned in live this evening. So if anyone watching tomorrow on demand is wondering why they can't redeem it, that would be why. A final just point on GastroAid, just to note that GastroAid will be available to buy at the Natural Dispensary in a few weeks' time. So you'll also be able to buy it there, as well as our website where you can currently find it. I also just wanted to remind everyone that you are all invited to sign up to the DR.VEGAN Practitioner Scheme. By signing up, you unlock a number of fantastic benefits, including commission on sales, clinical reviews, free products, and other practitioner-only perks to support your clients and help really elevate your practice. We will be sending details of how to sign up in our follow-up email tomorrow, so look out for those. And a final reminder on questions. If there are any further questions that you want answered, please reach out to Ella. Her email address is there on screen, ella@drvegan.com. You just email her, she will be able to help. And if it is a question specific to Richa as well, she'll be able to pass that on. So we will get back to you either way. And all that's left to say is a huge thank you to both Ella and Richa for hosting this evening. It's been a great way to kick off our first webinar in our brand new series. And I know that there's lots more very exciting things to come. So thank you both. And I hope everyone has a lovely rest of their evening. And yeah, I hope that we see you all soon in our next practitioner webinar. Details of this will be available soon. So thanks very much, everyone.
Thank you, Emma.
Thank you.
Thank you, everyone, for listening.